because far too long, the word prevention has just been hijacked to mean anything. Naloxone is prevention, and harm reduction is prevention, and even treatment can be preventative. And then funding to primary prevention goes away because everybody's doing prevention and the primary prevention work gets lost. So here we made it very clear in the prevention strategy, chapter 5, creating a drug-free America as the social norm, that we are talking about primary prevention, preventing drug use before it starts. That's what that means. So we made that very clear in the definition. And then for the first time ever, we have that prevention framework, because there was so much that we wanted to write about prevention, it didn't even fit into the chapter.
This is Pathways to Prevention, the podcast that sparks conversations shaping the future of drug prevention and recovery. Powered by the Drug-Free America Foundation, we bring together leading voices like policymakers, researchers, faith leaders, prevention experts, and real-world changemakers to tackle the biggest challenges in the fight against substance misuse. From breaking trends to innovative strategies, we explore what works, what's next, and how we can all make an impact. You're here because you care about creating a world free from the grip of addiction. Together, we'll uncover the stories, solutions, and strategies that drive meaningful change. Thank you for listening. Now, let's get started.
Every community in America is touched by the drug crisis in some way. Maybe it's a family member, a neighbor, a kid on a sports team, or maybe it shows up in a statistic that represents somebody you'll never meet, but whose life mattered just as much as anyone else's. Now, the federal government recently released the 2026 National Drug Control Strategy, and today I have the rare opportunity to sit down with the person who helped shape the public health side of that document, Dr. Roneet Lev, the Chief Medical Officer at the White House Office of National Drug Control Policy. She's a board-certified emergency physician and addiction medicine specialist who came to this work the same way a lot of us did, from the front lines, seeing the crisis up close and deciding that proximity was not enough. Dr. Lev, welcome to the podcast.
Dave, I'm delighted to join you.
I'm excited as well. I know we'd crossed paths a couple years ago at C&D, and so I'm excited to continue that conversation and get to know you even more as well. And that's where I'd really like to start. Before we jump into the strategy itself, I'm curious about the human being behind the title, emergency room physician, working in addiction medicine. And you made that decision to go to Washington as well. Can you kind of walk me through that a little bit? What led you to where you are today?
Well, thank you for that. Reflecting back, I did not see myself as a little girl saying, oh, one day I'm going to go to the White House and be an addiction medicine doctor, because there was no such thing as emergency medicine doctors in those days. And there was also not really such a thing as emergency physician in those days. When I was little, I was the first person in my family to go to medical school. I thought I'd be a pediatrician because I liked children. And so I volunteered in the summers at a pediatric hospital, and they mentioned, oh, maybe you would like emergency medicine. So I fit that profile of a multitasking action kind of personality that fits in emergency medicine. And at the time I went to medical school in Texas, there was no such thing as emergency medicine training in the entire state. That's how old I am. So one of the first in the generation to do that specialty. And what led me to addiction medicine is really a personal story. I had someone in our community who overdosed, and we heard about it. I remember at the synagogue on Yom Kippur, and I went and visited the family as they said goodbye to their child, Aaron Rubin. I remember his mom and dad, and I went to visit, and it was very heart-wrenching. And Aaron didn't die. He ended up in the hospital for months, ended up in a coma, and came out of it with paraplegia. And his mom became an activist with the opioid prescription epidemic at the time. Her son overdosed on oxycodone. He got a sports injury and then developed pain medicine addiction and was in recovery. And then friends, quote unquote friends, gave him a pill, and that's what happened to him. And his mom, Sherry, reached out to me as an emergency physician, why are you guys prescribing all these opioids? What is happening? And she really activated me and introduced me to the parents who showed me the harms their children were getting into while we were taught to prescribe. We were pushed to prescribe. And that motivated me. They say physicians do no harm, and we were doing harm without knowing it because that's what we were trained to do. And I activated the medical community in San Diego at that time for safe prescribing to get us on the same page to undo what we were taught to do. And then that went to California and then nationally. And that's what led me to work for the first Trump administration and then get board certified in addiction medicine as well. But that's how I got here. And since then, I always listen to the parents. Parents have been my moral compass that got me into this field. I have pictures of all the people who tragically died, and I don't want them to die in vain. I want to remember every single day, every single minute that I'm here, not just for me, but for the entire office of why we do what we do. And at first it was the parents who lost children from the oxycodone and pain medicine epidemic, and then fentanyl. And we also remember the victims of marijuana, the people who've died from marijuana harms as well. Or any drug, it doesn't matter what drug. These are all potentially preventable deaths.
If I were to extract a theme from that, please do correct me if I missed the mark a little bit. But going from treating sort of individuals to affecting change in healthcare systems locally, I'll say locally, San Diego, and then now changing the environment as a whole in the country, sort of moving more and more upstream, to use prevention lingo.
Yeah. And I always take my experience in the front lines of what's happening to be an advocate. And I think, the emergency department is a great place to see that because they say all the world's a stage and people in the emergency department have the front seat. So really, we're the canary in the coal mine, what's happening in societies. You see that not just with drugs, but for whatever else, right? If it was gang violence or elderly falls or whatever, we see the things that the problems in society, especially the medically related ones, socially related ones. And I'm not the only emergency physician who sees that, and it activates them to do what you love to do, which is prevention, right? And yeah. I think the prevention activists I've met throughout my life really affected my career, because I will see a person who fell and broke their hip, right? And I know how to fix a hip. I know what to do with that. But I always take prevention. What made you fall down? How do we prevent that fall from happening again? You had a heart attack. Now, how do we prevent you from having that again? So I always think about that with all parts of medicine. And it's really the drug prevention activists who really put that in my head permanently.
Yeah. And I kind of wanted to tease out that theme a little bit because it resonates oh so well with mine, in that I may have shared previously, I came back from Iraq for my combat deployment with an undiagnosed traumatic brain injury and PTSD and moral injury, and then used alcohol to cope, hence picking up addiction and struggling with that. But I found my way into recovery. And I know a lot of folks in recovery will become recovery advocates. And for me, it's that going upstream. What can we do to help other folks not have to go through the same struggles that I had to go through as well? How can we change the conditions, the environment, build up their internal capacities? Yeah. Okay. Yes. Anywho, but let's talk about that strategy a little bit, because I see a lot of both your story and my story showing up in the 2026 strategy itself. From my early days working as a campus police officer on a prevention coalition, I didn't know there was such a thing as a strategy. And as I started to grow in my career field, I knew there was this strategy. But even as a boots on the ground practitioner, it was just this fancy formal document. So can we talk for a little bit about what is the strategy and what does it mean to the boots on the ground folks doing the prevention work?
Yeah. So thanks for asking. We are so excited and very proud of the 2026 National Drug Control Strategy. This is a document that dictates to all of federal government the policy, the drug policy that all the agencies need to follow. There are $44 billion in federal money that goes to 18 different federal agencies, so Department of Transportation, Department of Justice, Health and Human Services, etc. And any one of those federal agencies that touches the issue of drug has to follow this strategy. This is a strategy that needs to be followed. So it's really important in that sense. This is a way of telling the government, well, this is our pathway in dealing with drugs in both the demand side, supply side, emerging threats, etc. So that's the importance of it. Our director, Sarah Carter, she's really a woman of the people. She's the first female drug czar, and wanted this to be a document dedicated to the American people. And so we also dedicated to the people who have been lost in the strategy. Now we have a memorial page, an acknowledgement that this strategy is for the people. And there are some practical tips that people can use. Our prevention framework has some tips like that. And for coalitions, drug prevention coalitions, it tells people like where we're going with that as well. But the action items, and we hold our interagency accountable to this strategy. So we have action items, we have measurements, and then we follow along and say that this is what we expect to see coming out. So that's like the overview of why it's there, why it's important. And then if we can talk in more detail about the specifics that are in there, and that some things that are in there are historic. For the first time ever, we have faith in a government document such as this, and I'm really proud of that. And really, thanks to President Trump, listening to him, he had a commission for religious freedom, and I went and I listened to the president, and I came back and I said, I dare anybody to edit out God out of the document. We have the president behind us in this, and so despite the legal advice, like, oh, you shouldn't put God in a government document, we have it in there. We put it in scientific terms that 83% of Americans believe in God or a spiritual power. We don't want to force religion on people, but if you have this a faith in your heart, use it. You should use it for your prevention work and your recovery work and for treatment. It's a special sauce that you have. We want you to be able to activate it. So it's there for the first time, and we're proud of that.
And let's talk about that for just a minute. We'll go that. Well, yeah, we'll throw the script out the window because, yes, seeing faith prominently talked about in the strategy, to be honest, at first when I got to that point, I kind of paused and I scratched my head a little bit and I'm like, I'm curious. I want to know more. And, the 83% of Americans do have faith in God in some manner. And not just how integrated faith is in many treatment and recovery programs. It's at the core of many of them, but also just from my own lived experience, knowing that, needing that hope, and that sense or that feeling of hope can come from so many different places. And faith being one of the biggest ones, it started to make sense. It did. And the last little thought here too, that as I was pondering this and prepping, I was trying to think about it from just the prevention coalition leader's perspective. And to me, it's a signpost, a signal, a nudge to, hey, engage your faith leaders more.
Yeah.
They're often there in the rooms having conversations before crisis takes hold. They have access to communities. They are a great influential leader. People listen to them. And so, we need to be partnering and engaging with them too. Not really a question in there, but kind of just sharing some of my initial thoughts as a reader of this strategy.
I'm glad you said that because your experience is exactly that. And you have both the personal experience and the professional experience. And when you saw that, it rang a bell of truth. And for so many years, we've segregated that parts of your life. So you had that faith, but you had to put it in a different part when you were like working professionally, or even as a patient, you had to put it separately. And so this is giving permission that if you have this, again, we're not forcing religion on anybody, but if you have this, use it. It's a special power that you have, and you should activate it and use it in your prevention, treatment, recovery. It's helpful And there's science and evidence behind that, right? If you, people who get prayed for, right, have better chances. General surgery, right? We have this in the rest of medicine where we know that it works. Why not use it in this aspect?
Absolutely. And it just so happens my shirt today, I know listeners, this is audio only, but my shirt literally says prevention is hope in action. And just the power of hope and how faith can bring about that hope to folks in their times of need. Absolutely. And so another thing that really kind of got me to pause as I was reading the document, asterisk, I didn't read all 195 pages, but
you didn't.
I didn't.
Really? It's
Confession
not.
here.
It's meant to. It's more like a dictionary. You're going to read the sections that apply to you, right?
Yes. And it was an easy read. Even just from the appearance, it didn't look like a bureaucratic document. It had pictures of people in it.
I love that. We had pictures. I fought for those pictures. Kind of like I forgot in the document. It's like, well, this is a document. It's not professional to have pictures. If we want pictures, the director said she wants this as a document for the American people. And like, so she empowered us to have pictures and stories. And I hear that even the president, saw that this was a pretty document. So you can like scroll and look at the picture. Some people just go to the picture parts and read that. That's good.
Right. Well, the other big thing that really got me to pause and kind of tilt my head in that, I want to think more about this manner was, I believe it was page 6, where it said preventing substance use before it begins is one of the most effective ways to protect public health, strengthen communities, and reduce long-term social and economic costs of drug use. That's like my song. I want to sing that from the highest mountaintops. But I paused and I thought, coalition leaders, like we've been making this argument for years. We've been saying it works, but we don't always feel heard. And that sentence right there just gave me the sense of, okay, somebody has been listening. They do hear our voices. But what does it mean to have that kind of commitment at this level, saying such a bold statement?
Well, first of all, it's true. And it's true not just for addiction, it's true for any medical illness, right? Or any catastrophe, right? It's better to prevent a fire, right? Than put water over a building. That came from Benjamin Franklin. President Franklin's coined the phrase, an ounce of prevention's worth a pound of cure. And that came from fire protection. But that's true for, right? Better to prevent diabetes than become diabetic. It's better to prevent cancer, skin cancer, and put on some sunscreen than treat your melanoma, right? So that's true for all parts of medicine. And it's true for addiction too. So if we know the brain is growing till age 25, and we also know that during that tender age of brain development, addiction is up to 7 times higher than someone my age. If we make a very focused effort in preventing drug use at least till 25, if not for a lifetime, we would automatically have less addiction in it.
Yes, indeed. And I think I want to come back to this in a little bit and talk more about the importance of prevention, because as you know, I've dedicated my life to prevention. So it's something I could talk about for hours and hours and years and years. But I want to go back to the strategy a little bit more too. Mentioned, historical to have faith involved, but the prevention framework too. You'd mentioned that, but tell me more about that.
So the other thing that's new in the strategy also to come to prevention is that, people in prevention know that there's different types of prevention, right? There's primary, secondary, tertiary prevention. We made it very clear in this document that when we're using the word prevention, we mean primary prevention. Because far too long, the word prevention has just been hijacked to mean anything. Naloxone is prevention, and harm reduction is prevention, and even treatment can be preventative. And then funding to primary prevention goes away because everybody's doing prevention and the primary prevention work gets lost. So here we made it very clear in the prevention strategy, chapter 5, creating a drug-free America as the social norm, that we are talking about primary prevention, preventing drug use before it starts. That's what that means. So we made that very clear in the definition. And then for the first time ever, we have that prevention framework, because there was so much that we wanted to write about prevention. It didn't even fit into the chapter. So we wanted to give, what prevention means, and empowering parents, having authoritative parents and parenting, and for parents to say, you know what, I expect you not to use drugs. Just like I expect you not to cross the street when the light is red, and for you to get better grades, or whatever as parents do. If you make that expectation, kids listen. How to know when, drugs or herbal substances are safe. We have a picture of the USP seal there in the strategy. To show, I need to take vitamin D. How do I know when I'm buying that from the store that that's really just vitamin D and doesn't have like arsenic or lead, and it really does have the 5,000 units that I'm buying? Because that is tested by a third party that follows standards, and it has a USP seal on it. And that's how I know that that is what I'm taking that's safe. People are buying marijuana or hemp products or psychedelics or whatever it is that's in the smoke shop these days. None of that has gone through any type of testing. And you really don't know what you're buying. You can't count on the labels being correct. Well, we have little tidbits in that to kind of get more details. I mean, it's not comprehensive. That's why we call it just a framework, but it really has coalitions in mind with different ideas that can go to. I say, being around coalitions for so many years, there are so many good ideas, and then you find out what resonates to you and your community, and then you can run with that. So these were like ideas of what to do and to empower you. And I'm so glad that you felt the strength and importance of prevention as you were reading the strategy.
Yes, and even in that same chapter 5, in building that healthy, drug-free America as the social norm, I do a lot of work with Dr. Jeff Linkenbach in the Montana Institute. And so I always make smile when folks include the folks that are drug-free, that are choosing not to use, and showing it right there in the strategy as well, that, calling out that 214 million Americans are drug-free. That's 74.5%. Rather than just focusing on those numbers that show the problem, also showing the other side as well. But we have to balance hope and concern.
And emphasize that, right? So like when I took care of patients in the emergency department, we always ask, do you smoke or drink or use drugs? And people say no. And I'll say, good for you. That's a social norm. Most people are making that choice, especially for kids, are making that decision to protect their brain. Good for you. It took me 15 seconds to say that. And that you never know what kind of a lifelong impression you have as a doctor and a child in an emergency room by making that short little investment in that person's future to emphasize that social norm.
Yes, and growing the good that already exists. And yes, so that just chapter 5 alone made my heart happy and felt like a good reinvigorate a tired prevention field, but then seeing.
Well, and I learned that from the prevention specialists and from the field of prevention science to frame things in a positive and not a negative. I don't want to say don't use drugs.
Yep.
We're going to say be drug-free, right? We really wanted it really careful with that positive messaging.
Absolutely. And so I'm curious, close roots with coalitions, work with them quite a bit. And so the listeners already know that this document is different than the past ones. It's got pictures, it's got faith, it's got the prevention framework, and you got an Army infantry ground blowing up that says it's actually a pretty easy read. So they're probably just about ready to go download it. When they get that in their hands, what would you recommend their first or second steps be once they have the document and are reading it?
Oh, look at it. You could, thumb through, look at the pictures. And if you're, and look at what resonates to you. I mean, the summary, when you get the document, it looks very big because it's several documents together. It has all the strategy, but it has several annexes, and it also has the performance measures, and we combine multiple documents into one big one. So don't be intimidated by the size. If you're a prevention coalition, look at the summary of the whole thing, thumb through the prevention chapter and look at the prevention annex. That's not long. And it should definitely make you smile. There are other parts besides prevention. I don't know if you want to go there yet.
Yeah. Let's stay with the strategy.
All right. So we'll talk a little bit now, emerging threats, which is our very first chapter. And this is also kind of historic in the vision where we want it to be. And I tell people that I've been jealous of infectious disease, jealous of gonorrhea and chlamydia. Why? They get mapping, they get attention. We treat the partners. There's a whole public health effort just on sexually transmitted diseases. Now I don't have to say that anymore because we had all this effort about COVID, and we remember those days. Sometimes we want to forget about those days. But there was a whole public health effort on, testing, tracking, tracing for COVID. The whole time I thought we need to be doing this to fentanyl. At that point, people were dying of fentanyl. COVID was number one, but fentanyl should have been number two. But I think we need to apply that same public health, infectious disease strategy that we have to drug threats. So the vision is to have data available in real time of what drug threats are from not just from deaths, but also drug seizures, hospitalizations, consumptions, all these data sources in one place, available in real time or near real time to the community person, whether it's the doctor in the ER or the prevention coalition or whoever else. And that's the vision of where we want emerging threats to be. And we've partnered also historically with the CDC for HAN alerts on medetomidine, and we're going to be publishing more advisories. So, not waiting years later to say so many people died and this is now a drug threat, but really trying to be more on top of it. And so people in the community can you do better, right? I've always said I'm a better doctor because my partnership with law enforcement, because they tell me what my patients are taking, otherwise I wouldn't know.
I sort of hear two parts to that, and that one being more timely and just here's what we know, here's what we've seen.
Timely, consolidated, and multiple sources, and coming to the end user. We're not there, but that's the goal. That's where we want to be.
And making it accessible to folks, to us, to be able to then use, to learn from, and work with.
Right.
Yeah.
When we rolled out the strategy, we had a panel discussion with an emergency physician, head of the emergency department, American College of Emergency Physician, American Society of Addiction Medicine, and the doctors all like, we need that. We want that. That'll help do better in our job.
Yeah. And what I hear too, talking infectious disease, COVID, how we united, we have the infrastructure, the systems, the processes, all of that exists. It's there. It's not necessarily oriented towards drug prevention or primary prevention or anything along those lines. And that's sort of the shift is we've got it, so let's focus it.
It's more like not primary prevention is what you do with that information, but that information also, it applies to everything. This is data that helps inform your decision making, whether you're into primary prevention, whether it's treatment, whether it's recovery, knowing the dangers, whether it's supply. This is making smart policies based on data.
Bolstering that infrastructure and opening up the communication pathways, to me, will help move the prevention, treatment, and recovery space more away from being siloed or fragmented to really functioning and being able to talk the same language and learn from each other. And instead of we're over here doing our thing, using our own language, we don't talk to you, you're in your silo, and so forth.
And those datas are siloed, right? We're trying to connect those as well.
Yes, exactly.
Right. Yeah.
Moving from that fragmented ecosystem to one that really is truly functioning, and everything is interconnected. We need to be that level of interconnected if we really want to function and thrive.
And the other thing in the strategy, it's not primary prevention, it's the next chapter, bringing help to all stages of addiction to the mainstream. It is really bringing addiction medicine to the mainstream of healthcare like any other chronic disease. And we use the public health river analogy. And the river analogy, most people are aware of it. There are people who are drowning in the river. Everybody's there rescuing. I think of myself in the ER, like ambulance come with people who have drowned and we're doing CPR or whatever we need to do to rescue them. And all the people are taking people out of the river. And then one person leaves the group and says, "Where are you going? We need you here. We need you here rescuing people." And goes, "I need to go upstream and figure out why people are jumping and how to prevent that." But we want to move upstream also in our treatment work, right? And again, using the chronic disease model, we want to do pre-diabetes, not wait till you need to be on an insulin pump, right? We want to take care of your small little skin lesion before you have stage 4 melanoma and you chemotherapy. Of course, we'll be there throughout for your medical needs. But if we go upstream in your treatment, find yourself when you're misusing drugs, find yourself early in the addiction instead of waiting all the way till you have full-blown 11 DSM-5 criteria for your substance use disorder. That's going to be just a lot harder to treat. Not that we want to be, it will be there for you. But if we shifted things to early detection, intervening early before you even have an addiction, then we'll be better off, just like with all other chronic diseases.
Absolutely. Absolutely. And I mean, even just thinking about my own recovery, my own healing, as I call it, and I like to say healing because it was so multifaceted and moved beyond just one diagnosis. It was traumatic brain injury and how that interplayed my neurotransmitters, my moral injury and the injury to my soul, my PTSD, my anxiety, and then my addiction as well. And so,
and Dave, I bet your medical care was siloed, right?
Absolutely. Mm-hmm.
Yeah. So you're like, even if you're PTSD, you probably saw a mental health worker. And then for your alcoholism, well, I don't do that. You have to go to someone else for that. And so at the end of the day, the care that you get as one human being is very fractured instead of consolidated and understanding. So we want to do that. So one of the things, again, a lofty goal, we have lots of lofty goals, is to have addiction medicine services, addiction consult services at every major hospital in America, right? If you're a major center, then there's probably 10% or more of the patients who are in your hospital have some type of addiction that's an underlying cause of their illness that's not being addressed. So we want to do that. And with that, it will go downstream and hopefully, ideally, the care you would get, Dave, is that you would be able to, each specialty is different, right? So if you talk to a neurologist, but they would understand at least the mental health component and the addiction component, and maybe you needed 3 different providers, but they would coordinate together.
Absolutely. But breaking down the silos is ever so important, but then also moving upstream. Yeah, I love that. And just in my time as a police officer on a college campus, I embraced that spirit. I took motivational interviewing out with me on patrol and to create that jumpstart to change. It was so wonderful to, rather than wait for the students to reach a crisis point, get referred into student standards or get an underage consumption or have to go to the court system. Let's just have a conversation and how that conversation in 15 minutes could actually change the trajectory of their lives.
That's awesome.
It could. But what about the recovery chapter? What's new there?
So recovery chapter celebrates and supports recovery. One of the things that we're working on now, we'll see how, we have, again, more lofty goals, but for everything that we're doing, we want to kind of up the bar and bring science to it. So we don't want just prevention work. We want it to be evidence-based prevention science. If there's going to be curriculum, we want it to be certified and have an academic standard, right, for prevention work. And we also have that in the recovery. So we really want to encourage more employers to have certified recovery-friendly workplaces. So if you saw that, if you were looking for a job, you'd see a little seal, it'll be recovery-friendly, and you'll think, oh, I can apply to this place, right? It's friendly, and you would know immediately what that means. So we want to encourage more employers to take certification to show that they are a recovery-friendly workplace. So that's one of the things. Besides just, there's 25 million Americans living in recovery. They are a model and an example that recovery work. I think we're a leading nation. When we think about, your work with the United Nations, America is probably the most friendly of every place on earth that has recovery-friendly workplaces and understands that. So we want to grow that and celebrate that. And the other thing that people in recovery bring is, I think you can be studied on how to get there, because not everybody, and you give a good example, not everybody received medicines to get recovery. I was saying this as a doctor. The pathway to recovery, is individualized, but by learning about those pathways, I think we as a health professional can get better and more effective in what we do.
Absolutely. And what I've seen in working with connecting with individuals and communities in recovery is that they are great, I'll say, catalyst at connecting folks in a community. They want to bring, treatment, faith, employment, family all together to create that supportive community to help both them thrive. But then, to me, as the prevention lens, that shapes the environment and creates and supports that social norm of drug-free as well, to serve as a support prevention outcomes essentially too. So yeah.
Yeah, I think the connection with recovery and primary prevention is a good one, because they tend to have the same goals, which is abstinence. One of the things that we did, we worked on a toolkit for best practices for treating addiction in the homeless population. The toughest one. And people, when we started to do that, it's like, why are you picking that population? It's like, well, it's the hardest population. It's the ones who have the most severe disease. And if we can tackle that, it will show an example to others. And a lot of people who are working in that sphere are in recovery. So they are a living example, and they're giving back and thankful for their recovery by giving back and help others achieve the way. The thing that's different is that we're really embracing a treatment-first model. It used to be homeless first, but we found out that when you just give housing without treatment support, people can die. And being homeless is a deadly condition. If you are homeless, you have a 3 times more chance of dying of anything than someone else your age who has housing, has shelter. So it's a very susceptible population. We created this toolkit in order to show how to take people who are homeless, who have addiction or mental health problems, and bring them to the goal. The goal is not housing. The goal is self-sufficiency and thriving, and having your addiction managed and being abstinent, and having your mental health condition stabilized, and be able to be self-sufficient and have high goals and high expectations for individuals. And you know what? It's possible. And we brought in experts from across the country who deal with this population and have been successful with the treatment first model, and to create this toolkit in order to teach how to do this nationwide.
Where can we send folks to learn more about it or stay up to date with it?
We have almost done.
Okay.
It's not yet. We had the summit, a 3-day summit with these experts. It's almost published, and we will have a press release when it's ready for everyone to see.
All right. We'll keep an eye out. And so this might be a big question. Okay, Dave, it is a big question. So take your time to ponder or punt, all good. But we talked from emerging drug threats to prevention, faith, the framework. We talked treatment, recovery, and how, using my words, how to integrate and not be so fragmented or siloed. When you visit a community that's doing all of it well, doesn't have to be perfect or textbook, just doing it well, what does that look like?
Well, I'll just take my community in San Diego as an example. And what stands out to me in San Diego is the level of collaboration and coordination. When I was in San Diego, I thought a committee called CREDO, Community Response to Drug Overdose. And every month we had the head of public health, the medical examiner, our law enforcement directors, our district attorney's office, U.S. attorney's office, emergency departments, EMS, on a call monthly. This is extra from what everybody else was doing, but they would want to be on this call and share what's happening on the grounds. Mm-hmm. And we would able to listen and intervene by that. So we were able to say, you know what, if there's groups of overdoses, there are children who are endangered. This is where they need to be connected to and be tested, because they could be positive for fentanyl, even though it's not positive, or get grief services. Or one time there were a child back in 2017, an infant, 6 months old, who needed CPR and went to different hospitals, received epinephrine, intubated in ICU, and it ended up being a fentanyl overdose. And at that time, who would think a baby would drop and be unconscious for fentanyl? That was not heard of. But we learned that and put a bulletin out to all EMS and the emergency department, like, baby down, do your regular ABC for of evaluation, but also think D for drugs, give them naloxone. And the next month we met, and that's exactly what happened. We knew about that. Really, we said that we're connecting the 3 Ps: public health, public safety, and all for prevention. You learn about what's happening in your community, and we're able to act upon that. And I'm really proud of San Diego. I guess that's where I'm coming from. But they're continuing to do that. And I hear from them, they inform me, like nitrous oxide. That's the latest threat. They're seeing that in these smoke shops. People are buying nitrous oxide and getting burned, activating the burn center to be able to treat with these burns. So they're seeing it connected with impaired driving on these, nitrous, something that's legal, not illegal. So they're able to detect these new community threats and act upon them in the community. And I think that type of collaboration is what a strong community does.
Is it okay if I call that a coalition?
Yeah, it's multiple coalitions. Yeah, they have like 100 different coalitions that all meet together. It's called the Substance Use Overdose SUOP, Substance Use Overdose Prevention Task Force. And they have 100 different coalitions from various sectors. They could be law enforcement or prevention or recovery or treatment. And they have all these different sectors of coalitions coming together. And then they have subcommittees. So mine was like a subcommittee of that, of how to get together a community and tackle different things. So yeah, that is a multiple coalitions acting together even.
Yeah, it's like a coalition of coalitions. Yeah. I wanted to throw that word coalition out there because that was another thing named in the strategy, is that essentially the strategy explicitly says the coalition is the best vehicle for change, the best agent for change in a community as well. And that the full support is behind the Drug-Free Communities program, still prominently named in the strategy.
Yep. Multiple coalitions. That's how you make things happen. And because you care, because this is where you're raising your children and your grandchildren, where you're growing up, where you're working. So you care about your community.
Yes, absolutely. And got, I would say 2 questions left, but before I do, I want to know about marijuana, not in interview interrogation along the lines, but just what does the strategy say about marijuana?
So I'm glad you asked that because it shouldn't be controversial that people with an addiction should get treatment, no matter what drugs they're addicted to. And the fact is that the number one drug of addiction is marijuana. And for the first time ever in the history of the United States, the rate of substance use disorder is over the amount of alcohol use disorder because of marijuana. So people are suffering in our country, and our strategy acknowledges that and directs efforts toward treatment. So if people have a marijuana use disorder and they have an addiction, they should be able to stop. And we should be, even if there's not a medicine for it, there's plenty of people who stop smoking cigarettes without a medicine, right? And there are medications for nicotine use disorder, but many people are able to quit and with the guidance. And we want that ability for people who have a marijuana use disorder. We also want people to make informed decisions and understand the dangers. For example, there are hundreds of medications that interact with marijuana. So if you're using marijuana and you're also on a blood pressure medicine or a blood thinner or on psychiatric medications, you should look it up and we have in our prevention framework, we have in there, one of the tips is to use drugs.com and put in cannabis or marijuana or cannabidiol for CBD and checking that against your medications or grandpa's medications. So you make an informed decision and then you can decide for yourself if you want these and be alerted to the potential side effect.
Wonderful. So there's pretty plain and straightforward. That makes sense. That makes sense. I like that how you put it doesn't have to be controversial. What else have we not talked about that's in the strategy or that you'd like to talk about and share with our listeners?
The only other kind of chapter or section that we didn't cover is a rescue and overdose response. So we do, sadly, the reality is fentanyl has infected, and use that infectious disease word, but fentanyl has infected the entire drug supply. And nothing is safe these days. And that's why we really do need naloxone around and new emerging pharmaceuticals such as sequestrants that will be helping with that type of rescue. And along using that river analogy, there's some people who they're not even in the river. They don't have a pre-addiction and they're not addicted. They're just a baby who was crawling on the floor of the Airbnb and became unconscious. There's a lot of lives, and everybody needs not just second chances, third, fourth, fifth, ninth, 10th. I have to talk to people. I'll ask them, how many times have you received naloxone? And I'll like 15 times, like a crazy, but we'll always be there for, so everybody, life is precious. No one is a lost cause. And no matter what, whether it's an innocent victim, like a baby who's being poisoned or somebody's just really in the shackles of terrible addiction, no one should die. And so we do have an emphasis on updating how we rescue that takes into account that people usually overdose of multiple drugs, not just an opioid. Taking that into account, we want to work on overdose clusters. We call it drug-associated mass casualties that happen, DAS. So we want to have like the best guidance or standard for when that happens.
Absolutely. Absolutely. And listeners, I will have a link to download the strategy in the show notes as well, because I know you're just itching to get your hands on it and read it. Last two questions, if you're ready for them.
Sure.
Got those big goals, the big goals. I think you called them lofty goals, but they're achievable. They are. So thinking about those goals, and we'll fast forward to 5 years down the road. What is the vision? And not talking like overdose rate is this number, but just what's visibly different in the lives of just everyday Americans?
Well, the vision would be really, we just celebrated 4th of July. It'd be being proud to be an American, proud of our country, proud of being who you are as an individual, whatever ethnicity, state, community, culture. You should be prideful of who you are, who your heritage is, and wherever that is, that'll be a calling to being the healthy, most productive you that you can be. When people want to do that, people want to take care of themselves, mind, body, and soul. And part of that would be the drug aspect. You're not going to be the best part of you if you're using drugs, if you have an addiction. So, that social norm, we call it pushing that social norm, but it's really in the bigger view, going even upstream from not using drugs is having good mental health, good pride in who you are, good self-esteem, and that all leads you to making the good and smart decision of doing what's best and healthiest for you. That'll be good.
Yes, indeed. And last question for our listeners, if you want them to just walk away with just one thing from our conversation today, what would that one thing be?
I guess the one thing is I'm proud of what you're doing. If you're listeners of prevention coalitions or whatever that they're doing, what you do matters a lot. And, it's actually not what the government could do for you. It's what you are doing for your community and for your family and for the example that you're giving in your life. So that'd be the one message. I think that's really important.
Yeah, and I couldn't have said it better myself. And so I just want to say, Dr. Lev, thank you for, of course, taking time out of your, I know it's incredibly busy schedule to chat with us and share with today, but even more so for being a prevention champion and advocate for those of us that are boots on the ground, doing prevention work, shouting as loud as we can. You're listening and you're actually advocating and trying to echo and share that message as well. So thank you for doing all of that work as well.
Thank you. Thank you to your listeners. And thank you, Dave, for having that flag and continuing doing your advocacy and important work.
Thank you for joining us on this episode of Pathways to Prevention, brought to you by the Drug Free America Foundation. Together, we're building a future where communities thrive and individuals live free from the burden of substance misuse. If you found this conversation valuable, don't forget to subscribe and share it with others who care about making a difference. Your support helps us reach even more listeners around the world. To stay connected and explore more resources, visit us online at dfaf.org. Let's continue to spark conversations, drive change, and create pathways to a healthier, drug-free future. Until next time, thank you for listening and for being part of this mission.